So welcome everyone, good evening, and thanks for coming again for the FOF in person. Today we have another debut from the research team. His name is Abhishek Goenka. He's an analyst in our research team at PPFAS Mutual Fund. And Abhishek tracks chemicals, Abhishek tracks healthcare, diagnostics, and pharma. So today one of his topics is on the hospital sector. Abhishek, over to you and welcome to FOF.
Thanks, Ronak. Good evening, all. So it's been a long time since we have covered a healthcare topic in the FOF. So Ronak has covered pharmaceuticals and the complex world of diagnostic in the past. The good thing is hospitals is a fairly easier topic to understand. So if we see the overall healthcare spend, hospitals comprises around 61% of the total spend, whereas pharmaceuticals is 20%, diagnostic is around 10%, and the medical devices is 9%. So hospitals is roughly almost 2x if we combine the pharmaceuticals and the diagnostic total spend in the economy. So these are few graphs. So I'll start with the top left hand side graph. So if you see the overall spend of GDP as a percentage, so it has been largely same around 3.3 to 3.8%. The last data of 2018 is around 3.5%. So if we compare it relatively to other economies, so we have been fairly lagging behind the smaller economies and even the developing world. So just for example, if you see Nepal or Vietnam, which are the smaller Asian economies, so they are almost like 6% of the total spend, whereas India is around 3.5% of the total spend as percentage of GDP. On the per capita basis, if you see, so we are way far behind at $73 as on 2018. However, if we see economies like USA, UK, the total spend is higher than the total per capita GDP of India. So these are basically 5 sub-segments which comprises the overall healthcare industry. So when it comes to hospitals, the government role is also equally important because they are the last mile person who involve the deprived poor people who would be able to get the healthcare facilities. So roughly the ratio is 1:2 ratio. So when we saw the 3.5% GDP as a percentage of healthcare spend, so roughly around 2.2% is a private expenditure and 1.2 is a government spend. Whereas the pharmaceuticals or diagnostic, it's largely a private play. There is hardly any government involvement. Medical devices is a booming sector. So in India, we hardly have any listed companies, something like Polymedicure or Opto Circuits or even Morpan Labs. But if you talk about the international USA market, so this has been a sunrise industry. So a lot of developments are happening in this industry. Last, medical insurance. So this is something which affects the overall healthcare industry, be it the hospitals, the pharmaceuticals or the diagnostic. So basically a person going for a health treatment will start his journey from a diagnostic health checkup. He will get a treatment and the medicines later on. So all these sub-segments are covered by medical insurance. So the larger medical insurance penetration will be there will be a higher spend. So these are few graphs on the bed densities on 10,000 population comparing with the global economies. So as on 2021, roughly India has 15 beds per 10,000 people. If you see the global median, it's roughly around 29. So we are at half the global average number. Similarly, on the personals of doctors or nurses, if you see, we have again a pretty low number. So the physicians number is 9 per 10,000 population, whereas the global average is almost close to 18. So again, if you see, Nepal is almost at par with India, with be it the physicians or the support staff. So again, something which we have to do a lot of catching up in the coming years. So this is a incremental bed addition, both in terms of completion of the beds as well as the announcement of projects. So this is a data just before the COVID, wherein new announcement have not come so far. So if we see last 4 years bed additions, so major hospital chains have added roughly around 67% of the additional capacities in tier 2 and tier 3 cities. So cities like Jaipur or Indore, which are mostly centrally located, so they have seen the higher presence in terms of new bed capacities. One reason is also that neighboring cities from being centrally located, so the neighboring state also provides a lot of support in terms of overall spend. Yeah, so the overall health insurance penetration is 36% as of FY20. And if you see the composition, so largely these are government sponsored schemes. So if you see in terms of absolute numbers, so total 450 million population is covered, out of which the total private coverage is around 137 million. So roughly around 13 crores is the total coverage, which translates to roughly 10% of the population. So in terms of private health insurance, we are very, very underpenetrated compared to global economies. So this is a trend of medical premium collection. So what we saw in the previous slide, in terms of volume, we have hardly grown. If you see FY16 numbers, from 273 millions to roughly 362 millions. Whereas in terms of value, we have almost doubled up from $3.82 billion to almost like $7.9 billion. So this is largely because of urban penetration in the insurance industry. Also, the coverage size has increased in last couple of years. So that has led to increase of overall value chain. But if you see in terms of penetration, it remains to be low. So this covers the out-of-pocket expenses, basically the patients that are spending from the own pockets. So this is something after your cashless insurance has been paid back or your reimbursement of insurance. So this is going completely out of your household savings. So if you see the countries that are here, so India is having the highest out-of-pocket spend, which is a major hurdle in overall healthcare expenditure development. Yeah, so if we see the countries that are covered here, so India is having the highest out-of-pocket expense. So this is a major hurdle in terms of the healthcare expenditure going ahead should be improving. So nearly 70% of the populations use their household savings on healthcare related expenditure. However, with the government initiatives like Pradhan Mantri Jan Arogya Yojana, we expect this situation to improve because government is trying to improve overall health coverage. So this is basically a classification of hospitals in terms of the services that they offer, the ailments that they treat, and the ownership structure. So if you see the basic services that are offered by the hospitals, it can be classified into three major segments: the primary care, secondary, and tertiary. Quaternary is basically an advanced version of tertiary segment. In terms of beds, they are having higher beds. So primary care is basically, it's more related to OPD, wherein the patient would visit to check out the diagnosis and he will get a basic medical facilities. They generally do not have any bed capacities as such. So they require very low investment also. Secondary care hospitals. So these are largely hospitals with 50 to 200 capacities. So these are mostly unorganized segment. When we talk about the listed hospital players, they would be classified in the tertiary categories because they generally have a larger bed sizes and specialized treatments. So any hospitals with bed size more than 200 would be classified into a tertiary segment. And quaternary would be even higher, something like 400 to 450 beds would be classified under quaternary. So this is a classification by ownership. So again, government has an important role when it comes to hospitals because a lot of healthcare expenditure in terms of capital intensive building is going up. So government has to play a very important role. So if we see like hospitals in Mumbai, let's say a KEM or a Cooper, they would be classified under a government structure. Under private, largely all the listed players would come, be it Apollo, Fortis or Max Healthcare. There are a couple of trust-based hospitals also, which are run and managed by the trust itself, like Lilavati and Induja Hospital. So there are few examples of the hospitals are managed by the trust, but run by the private companies. So one such example out of Mumbai is Nanavati Hospital. And hospitals owned by a private player but managed by another private player, there are hardly any examples. So there was one such hospital in the past, East Coast Hospital, which was run by Fortis earlier. So we'll see what are the major revenue and cost structures when it comes to hospital industry. So we can, so it's basically, they hardly have any segments like let's say a pharmaceutical or diagnostic where they have different products and services offered. So we can majorly classify it into two parts. inpatient services where the patient gets admitted to the hospital, and the another one is outpatient, which is more profoundly called OPD. So on the right hand side, we can see the chart wherein the IPD, in terms of value, so they comprise almost 70% of the revenue. Uh, However, in terms of volume, if we see, OPD almost contributes 3/4 of the volume, but they are a very low ticket size item. So, what would constitute a major segments in inpatient revenue is the most important is the surgery cost. That will be the single highest value item. Apart from them, there will be drugs consumption and of course the room rentals. OPD would be generally fees that is charged by the doctors, some consultancy and some diagnostic reports. On the cost side, so if you see the capital cost, so two major components are land and building and equipment cost. So land is the single most biggest item. So land and building would be somewhere around 40%. Again, it depends from metro to metro cities. If it's a tier 2, tier 3 cities, the land cost would be slightly lower than this. So equipment cost would generally be including say MRI or a CT scan would be coming somewhere around 5 to 10 crores. So it's a high ticket item, and also they have to keep reserve of 15 to 20% for replacement of such technology upgradation. In terms of capital cost per bed, so again it depends from tier to tier cities. Say it's a tier 1 city, a secondary care would cost around 50 to 80 lakhs per bed, where a high end hospital would be costing around 1 to 1.5 CR. So this is the operating cost structure. So this can be largely classified into three areas. One is the material consumed, manpower, and the other expenses. So manpower is something which is the major component when it comes to hospitals as an industry. So basically fees paid to the doctors is the highest component. Apart from this, materials consumed would include a lot of consumables, day-to-day basic doctors' kits, and other accessories. And other expenses are if it's a leased model, so operating rent would be the highest cost. So these are few of the listed players in the industry. Apollo being the oldest one, and it is also the Asia's largest healthcare company. So they have roughly around 7,600 beds, and they are running almost 44 owned hospitals today. They also have other segments, basically diagnostics and e-pharmacy. So the revenue is 50% comes from hospitals, and the 50% is from diagnostic and e-pharmacies. Similarly, Fortis is another relatively older name. They also have a diagnostic play through SRL Diagnostics. So recently they had a management change. So IHH Healthcare is a Malaysian company that has acquired the majority stake in Fortis. Apart from this, HCG is one such hospital which is into single specialty. Basically, they are into cancer treatments. So they are almost pan India present towards the oncology special treatment. Narayana is another player which is having a pan India presence. So if we see in terms of specialty, so it's largely cardio and onco, which is served by all the hospitals largely. KIMS is one such hospital which is having a very strong regional presence. Overall revenue of 100% is coming from the South Indian market. So this is a regional revenue mix of the listed players. So KIMS again is completely based out of South. Apollo is having a majority revenue coming from South region. Max is largely into metro cities, so 90% revenue is coming from Delhi, and roughly 10% is from the Mumbai. So they have a highest penetration in the metro cities. Apart from this, Fortis, Narayana, HCG are largely present into all the geographies. So some of these hospitals which is having a major regional presence, say a KIMS or a Apollo, so they see advantages in terms of understanding the patient's mentality. So what they say is it helps them in establishing a long-term relationship with those patients in terms of, let's say, their own regional languages or their culture, and it helps them getting a good bond with the patients. Similarly, in terms of hiring doctors and other workforce, so attrition in the hospital industry is very large. So if you see the average of 19, 20, and 21, so it has been upwards of 40% in all the 3 years. So having a regional presence helps them in lower attrition in retaining the doctors or the medical staff. So this is so various models are there when it comes to hospitals. How do they want to operate? So again, owned model is the most traditional method where the capital outlay is the highest. So they are trying new ways where the capital commitment is on the lower side. So lease contract where the major expenditure is rentals that they have to pay on every year basis. But the good thing is this allows the players to contain the capital deployment and making the expansion much faster than the owned models. Operation and maintenance contract. So this is further improvised version of lease contracts wherein you don't have to pay any fixed rental expenses. Basically, this is a piece that is paid every year, which is typically very low when compared to rental expenses. Medicity, so this is more like a health parks. So we haven't seen anything in India as such, but internationally these are very much prevalent. So it requires a big chunk of land, so which is generally outskirts of big cities, and they attract patients in terms of providing all the facilities in terms of specialty treatments. Franchise agreements, again, so there is only one company, Shelby Hospitals, which is having a franchisee-based services. None other player as far as the listed company is concerned. Expansion in tier 2 and tier 3 cities again. So if someone wants to build a low-cost hospitals, so this would help them in penetrating the smaller cities where the capital outlay would be far lower than the metros. So we'll try to understand this different models. So taking the example of Narayana, so they are largely present into all the models. So they have roughly 24 hospitals, wherein they have 4 of their hospitals which is completely owned by them, be it the land and the building. And these are their flagship hospitals based out of Bangalore and Kolkata. 7 hospitals are under the leased models. So leased models helps them in gaining quick traction, and these are leases from the government. So the leases period is generally very high. It could be as high as 10 to 15 years for each hospital. PPP is a public-private partnership. So they have 2 such hospitals, wherein again a large chunk of investment will come from the public enterprise. So recently they have done one setup in Jammu Kashmir. So the Jammu local government has paid for the infrastructure cost, and also they are absorbing the operating loss for the next 5 years. Revenue share, so again they have 6 hospitals where they don't have any fixed liability as such, but they would be paying a revenue based on the per bed collections. So they have 4 hospitals under the managed category. So these are basically large industrial houses which are running the hospitals for a social cause. So they are not in the business of hospitals. So that's where a listed player would come in and they would run the hospitals on the basis of some management fee that they would charge. So Nayana is roughly a very diverse model, and they have ensured that the capital outlay remains the lowest. So these are some of the other hospitals. So if you see Apollo and Fortis, so largely they have owned model. Apollo is having roughly 70% of the hospitals owned by the promoters, whereas in case of Fortis, all 100% is owned by the company. In case of Narayana and HCG, so largely they have opted for asset-light model. Both of them are having only 4 hospitals out of 20 plus hospitals. And in case of Esther DM, so it's a company which have more presence in the Gulf countries. So 80% of the revenue is coming from GCC-based countries. So there, the own model is not allowed by the government. So it's more of a operation and maintenance basis, whereas all the 19 hospitals in India are owned by them. So we look at medical tourism. So how this attracts international patients, which is again a major chunk of the revenue for all these hospitals. So if we see the cost comparisons, so just for example, let's compare angioplasty. So it costs around $5,700 versus 13,400 in Singapore or 17,000 in South Korea. So it's roughly around 1/3 of cost compared to other countries. Even let's say small treatment like dental treatment. So it costs around $900 versus almost 1,350 or 2,700 in other geographies. So we can see a lot of green bars in the overall chart. So this is one reason why a low affordability is attracting medical tourism in India. So overall, India ranks 7th when it comes to global wellness tourism and 3rd in the Asia Pacific. So these are the numbers foreign tourist arrivals on medical visa. So from 1,84,000 in 2014, so it's almost at 7 lakh in 2019. So this number has grown rapidly. So few of the reasons are having a good hospital facilities, skilled medical professionals, and more of the important reason is those countries don't have a adequate infrastructure facility in terms of healthcare. So people from Bangladesh, Iran, Iraq, Nepal would be visiting such hospitals. So the healthcare industry is constantly evolving in terms of technology. So government has come up with its new program, National Digital Health Mission, wherein they would be electronizing all the healthcare records. So whenever you visit a particular hospital, all your records will be available to the doctors. So this is still in the making, although the announcement has happened, but it will take some time to come up on the fore. Again, artificial intelligence, blockchains. So these are still in the making, but we can expect a lot of improvements going ahead during those periods. Uh, During COVID, we have seen mobile-based applications and telemedicine are someone who has gained a lot of tractions, and a lot of revenues have started flowing in for the doctors through these modes. Robotic surgeries again. So as far as India is concerned, we haven't seen any major chunk of revenue coming from this side, but international hospitals have already started implementing this. And wearable and sensors are, I think, more of a fashion product, so we are also using in largely day-to-day life. So we have already heard about fintech, which is getting more and more prevalence, but health tech is also not behind that. So India almost ranks 4th when it comes to attracting VC funding in the sector. So in 2021, we saw similar deals. So Tata Digital, a part of Tata Sons company, they acquired Tata One MG, 100% acquisition. Flipkart has announced their acquisition for Sasta Sundar Limited, a listed company, for its e-pharmacy operations. And Amazon has also done a tie-up with Apollo Hospitals for the front end of their e-pharmacy operations. There is a small this startup company which we must have heard over the advertisements on TV, Healthify Me. So they already have a user base of almost 3 crore people, and they are adding roughly around 500,000 new users every month. So a lot of traction is happening in this sector, and acquisitions are almost a daily affair now. So being a capital intensive sector, it requires a lot of government policies and support. And recently we have seen a lot of these yojanas have been announced by the government. So Ayushman Bharat is a flagship scheme of the government. So this is basically to achieve vision of universal health coverage. So this can be divided into two parts. One is PMJAY, which is basically Pradhan Mantri Jan Arogya Yojana. So this is the largest health insurance scheme in the world, which aims at providing health cover of rupees 5 lakhs per family to the bottom 40% of the population. The second is health and wellness center. So government will set up almost 1,50,000 healthcare centers for the poor people. So this should ensure that the poor people are getting some coverage of the healthcare expenditure. National health insurance is a long-term plan wherein they would like to cover the entire population gradually. National Digital Health Mission is again, so it's basically all the records of the patient should be under the electronic modes. So we have seen in US, if the treatment goes wrong, a patient can catch hold of the doctors. However, in India, it is yet not possible because we don't have such records. Generally, we visit any hospital or a doctor, they would always say, do a blood report, whereas it might not be even required for us. So this National Digital Health Mission is for those reasons that the whole records of the patient should be there in the electronic mode. So various tax incentives have been announced by the government. So recently they have announced under Section 80 IV, any new hospital coming in the rural areas with more than 100 beds, so they would be exempt from taxation for next 5 years. Also, they have reduced the basic customs duty for import of stents and artificial heart implants. FDI again, so they have improved FDI from 74% to 100%. And also in the health insurance, they have increased the FDI percentage from 49 to 74%. So government has taken some measures. Only thing is we have to see how much development happens through this mode. So these are the data from 2015 onwards. So a lot of private equity players have been active in the sector. Uh, in 2018, we saw acquisition of Fortis by IHH Healthcare, which is a global international hospital company based out of Malaysia. Radiant Life Care acquired by KKR in 2019. So a lot of deals have been happening by private equity. So one reason is they wait for the hospital chain to face some problems or almost on the brink of bankruptcy, and that is when they would try and enter the industry. So we'll see the comparison between listed Indian peers. So ARPOB is one of the important metrics. So it's largely on the lines of how we see ARPU in telecom sector. So our ARPOB stands for average revenue per occupied bed. So this is the data for last 3 financial years. So if you see the big 3 hospitals, which are Apollo, Fortis, and Max Healthcare, so they have a larger chunk in terms of ARPOB per bed. So Max is having a highest revenue of 56,000 per bed per day. And the main reason is again they have a higher presence in the metro cities. So 90% revenue comes from Delhi and 10% from Bombay region. Similarly, Fortis and Apollo are also almost there. Other hospitals, if we see HCG, again they have only one specialty, which is oncology. So they suffer there. Narayana have a lot of this economic weaker section tie-ups, so that ensure that the ARPOB remains very low. KIMS is again having 100% presence in the South India, but they are also in the remotest locations. So the ARPOB have always remained slow. But in terms of margins, KIMS have got a great margins. So when we see the breakup of ARPOB, so international patients are the highest contributory, followed by the self-paid and the insurance patients. So there is a slight difference between, let's say, a patient who is paying the hospital bill in cash versus an insurance patient. So it's a gap of roughly around 8 to 10%. And that is because the hospitals would have a price tie-up with the insurance company, which is revised every 2 to 3 years. So for a hospital company, they would prefer a cash a patient which is having, let's say, no insurance, be it reimbursement or a cashless. So they would be able to charge higher to them. So this is a breakup of region-wise international patient footfalls. So Delhi being the capital city, they have a better connectivity with all the global cities of the world. So they will generally see higher footfalls when it comes to international patients, followed by Chennai, Mumbai, and Hyderabad. So this is a occupancy percentage for various hospitals. So in hospital industry, any data between 70 to 80% is considered very high. Unlike hotels industry where we see 90 to 100% occupancy, these numbers are not visible in hospital industry because there is a layover when a patient gets discharged. So a new patient would come in and it will take some time to make arrangements. Also, there is a advanced booking system in hotels industry, which is definitely not possible in hospitals. So any number around 75-80% is considered to be very high. So in this case, if we see, Max is almost at 75%, KIMS is at 80%, and these are the 2 hospitals who are doing the major capex going forward. Average length of stay. So basically, this is the period that the patient is staying in the hospital. A number around 4 is considered to be best. Major reason is initially when the patient gets admitted, so a lot of these surgery expenses will be happening in the first or the second day. Going forward, there is hardly any major revenue that comes for the hospital. So generally, it's room rental or some nominal doctor's fees. So in case of HCG, if you see, the number is low because a lot of these cancer treatments will involve chemotherapy, which is a half day or a 1 day job. Revenue mix for patients. So if you see Apollo, they have a lowest revenue share from the scheme patients. So basically scheme patients are the ones which are prescribed by the government. they have to charge lower. Also, the working capital is long cycle. So generally it takes around 6 to 8 months to recover the money. Whereas for the peers, it's almost 15% plus. So these are the blended EBITDA margin for the industry, comprising of 8 listed Indian hospital players. So significant, if you see on the debt side, on the right hand side, so significant deleveraging has happened from almost 3.5x net debt to EBITDA, and it has come down to almost 0.6 in FY22. Even in the EBITDA terms, if you see the EBITDA margins have zoomed from 9% in FY18 to almost at 17% in FY22. So this is example of one hospital company. So what we saw previous slide was a blended EBITDA margin. However, the real way to look at it is would be what are the hospitals that are in the matured cycle and what are the hospitals in the new categories. So they will have a different EBITDA margins. So if you see, so this is numbers for Fortis for FY21. So they have roughly 7 hospitals which are the oldest one, more than 15 years old, and the EBITDA margin is upwards of 25%. So it's very important to look at the different hospitals at what cycle they are. In case if they are at a relatively new hospitals, so generally they have a lower EBITDA margin for initially 5-6 years. This is a blended ROCE for all the listed players. So again, it has improved almost 12% from FY18 to FY22. Again, FY21 was a bad year due to impact of COVID. One reason is net debt has also decreased from almost 8,000 crores to 4,300 crores. The bigger question is, with the capex spend again reviving, are these numbers sustainable? This is the capex trend of listed players. So if you see, the current capacity is around 30,000 beds, and the incremental capacity that is coming up in next 5 years is almost 11,500. So almost 40% incremental capacities are coming up. The major ones are Max Healthcare and KIMS. So again, we saw that 75 to 80% occupancy they have already reached. So they are almost doubling the capacity in next 5 years. HCG is more of a consolidation, so they are not making any new capex as such. They would be consolidating for a couple of years because they have yet to improve the numbers. So this is a valuation of listed companies based on FY22 numbers. So if you see the overall listed players market is around 1,63,000 crores, and the net debt is reduced considerably to almost 3,200 crores for all the players combined. On an EV EBITDA basis, the aggregate numbers are 21x. Max again is the most expensive company in terms of they have a highest EV per bed. So EV EBITDA is more profoundly used model in this case because they have a higher capital cost upfront and the depreciation and interest costs are also higher. So EV EBITDA is more preferred. So this is basically more of a summary. So what are those growth drivers for the hospital industry? So we saw government policies is very important because reaching the last mile, the lowest poor section of the society is very difficult for any private hospital. Change in demographics and rising income levels. So generally, if we see people crossing the age of 55-60, they would be require more healthcare spendings. So countries like Japan and Europe, so they are into this cycle. Increasing health awareness. So I think COVID has done more of the job in terms of the pills that we were consuming during COVID times has become more routine now. Change in disease profile is, so basically if you see the ratio of chronic to acute, so this has been increasing in last couple of years. So in India, we have seen these lifestyle diseases are becoming more common. So that leads to more revenue towards hospitals. Health insurance, again, this is a major hurdle for Indian companies. So we remain a very low penetrated country. So any progress towards improving the health insurance would be a driving factor. And last is the medical tourism. So again, we saw in the COVID times, this number has come down very significantly, but in FY22, at least the second half, the numbers have improved. We haven't reached the pre-COVID level yet. So these are some of the key pain points. So the major thing is government spend. So at roughly 1.3% of the GDP, that remains to be the lowest in the world. According to the National Medical Commission, so there are 12 lakh doctors in India, which translates to a ratio of one active doctor for every 1300 people. So which is very low as per the WHO standards. We have again, if we see the healthcare infrastructure, we have seen the previous slides. We are almost close to countries like Vietnam or Nepal, which is very below par. Similarly, on the regulatory intervention, so there are not much regulatory interventions when compared to pharmaceuticals, but recently, in terms of stent cost, where the price caps have come, so this could affect some of the hospital industries. Yeah, so capex intensive is one of the major risk area for hospitals when compared to the overall healthcare segment. So if we compare the three subsegments, so hospital remains the highest capital intensive sector in terms of capital outlay. If you see the working capital usage, it's generally low for all the three segments. Only in pharmaceuticals, there could be let's say businesses coming from South Africa, which could be let's say a tender business for few of the large cap companies, where the working capital would be having a higher cycle. In terms of regulatory risk, so there is hardly any regulatory risk in the hospitals or diagnostic, which again is the more prominent in the pharmaceutical space. In terms of competition, so there is very low competition when it comes to hospitals because the customer loyalty is very high and they would prefer a hospital which is in the regional province rather than traveling to the other geographies. So diagnostic again is a segment where there are very low risk in the overall scheme of things. So these are some of the sources from where this data is acquired. Yeah, that's it. Thank you.
Thank you, Abhishek. We'll take the questions from the live audience first, and then we will go to the Zoom audience.
Yeah, hi.
Yeah.
Firstly, thank you for a wonderful presentation. I think that's a great amount of knowledge that you shared. You talked about various forms of ownership, be it owned, be it leased. Could you comment on the whether the ROCs of those models actually work out to be really different? And what kind of trends are we seeing in the adoption of these models? Are hospitals being able to successfully move away from one model to the other, and what are the roadblocks? The second question is doctors as a percentage of cost, doctor fee. If you could share some longer term trends as to what we are seeing in the industry. Thank you.
So again, in that also, if you see the various models, the hospitals which are having a, let's say mature hospitals, life of let's say already 10 to 15 years, they have a better ROC numbers because they have already done the branding, they have already having the presence in the city for many years. Whereas if you see the hospitals which are still in the relatively newer cycle, let's say around 2 to 3 years, so they will have a lower ROC. So this is just a comparison between own model where a hospital is a mature hospital versus let's say a new hospitals. When we see the other models, with the lease, operation and maintenance, so in that operation and maintenance has better margins and ROC because even your rental cost is not there. Basically, you don't pay any fixed cost as such. So basically from day one, you're able to make some margins and only it's a revenue sharing model. So once you start making a higher revenue, only then you pay a certain percentage. So the best category is basically own model wherein you already have a larger presence for more than 10-15 years, followed by the operation maintenance, and third would be the lease models. On your second question, sorry, if you can repeat it. Yeah. So again, so few hospitals, they have a doctor's fees as a percentage of equity. So generally doctors could be classified into two parts. One is the resident doctors who are fully employed with the hospital, and one are the visiting doctors. So if you see, let's say Kim's hospital, so they generally have equity participation also. So they are given a set targets. So if you are able to achieve, let's say 50 surgeries per year, then you will get a higher proportion. So it would vary from hospital to hospital, But as a ballpark figure, if you see, 25 to 30% is the operating cost towards the pure doctor's fees, excluding the other, let's say, nurses cost or other staff cost. Trend rising. Yeah. So again, so if you see doctors as a percentage of equity participation, that in terms of absolute number, it will increase. But if you see the revenue that they are contributing to the hospital, that is also rising. So as a percentage of revenue, that is more static, I would say. Yeah.
Thank you. Great presentation, a very comprehensive one. So my questions are a little pointed towards the capex cycle. As you rightly pointed out, the capex cycle is reviving again for the hospitals. So do we have any historical data in terms how capex has impacted ROCs and how the multiples have been impacted in turn?
So generally, if you see any new hospital, it will take around 3 to 4 years for break even, and another roughly around 2.5 to 3 years to make a EBITDA neutral. So roughly it's a 6 to 6.5 years of cycle. Post that, you will see a significant jump up, whether it's EBITDA margins or even the ROE numbers. So in generally hospitals, as a blended number, if you see, 20% is said to be the highest benchmark. In case of Fortis, what we saw, few hospitals were around 25%, but as a blended, it was more closer to 17%. So as the life of the hospitals would mature, in terms of, let's say, a new capacity which is coming up, they would see a higher number. So at least 5 to 6 years is something which they will take for break even. And post that, you will see significant improvement in the ROE, ROC numbers.
And how the multiples have been impacted historically?
So yeah, I mean, in case of Max, what we saw, so they are almost at full capacity. The new capex plan is coming up. So when the whole cycle is completed, you will be at the peak margins. Similarly, in terms of we see Narayana, they have already announced almost 1,000 crores capex, where 500 is coming in India and 500 in international. So they are having on the lower side. So it has to be seen in terms of how much capex spent we have done. Once your capex cycle is nearing towards the end, the margins or even the valuations would be on the higher side. So one needs to see whether majority of the capex is behind us, or is it something which is going to come up. Once you have spent, let's say, 80-90% of the capex, that's when you will see the valuations on the higher side.
Okay. Second question again on valuations. Do you think EV/EBITDA would be the right metric to judge them? Because some of the companies, including Apollo and say Fortis, some of their revenue is also coming from diagnostics. And for Apollo, a lot of it is coming from pharmacy. So do you think EV/EBITDA would be the right metric?
So valuations is something which is more of individual preference, how they would like to pursue it. Apollo is slightly a different company because they have 3 different segments and all 3 are sizable in terms of be it hospitals, diagnostic or pharmacies. Whereas if you see, apart from Fortis, all other are purely hospital companies. So they hardly have any revenues from other segments. So for those hospitals, EV/EBITDA is more preferred choice for the obvious reasons, because bottom line cost would not be coming into play. For Apollo, yes, there are various segments, because the margins or the valuation cycle for all 3 divisions would be different. So for Apollo, a slightly different method would work.
Hi.
Yeah, hi.
You said that inpatient and outbound patient, 70-30 is the ratio.
Yes.
So what's a trend? Like what was 10 years before and what's now?
So
And
it's there in the slide.
Okay.
So IPD as a percentage of overall revenue in terms of value terms, if you see, so that has increased from 58, 60 to almost 70% now, and that is projected to be 76% by 2025. So that percentage is increasing as a percentage of revenue. In terms of volume, it's the OPD, which is almost like 3/4 of the volumes, which come from the OPD section. The only change that could happen is now these insurance companies are covering the OPD cost also. They are also covering this health checkup cost also. So we might see some change once this implementation happens, because it's a very recent event. But so far, what we have seen in last 10 years, the IPD as a percentage has grown up.
Okay.
It's around 70% right now.
And the margins, if they give.
So margins are not, disclosed by the hospital companies. But generally, OPD is the segment which is higher margin, because you hardly spend any time, you hardly spend on your infrastructure or those cases. But given the nature of the business, OPD will be the better margin numbers.
Hi.
Hi.
Mine is a more ignorant question actually. This healthcare scheme of the Pradhan Mantri, in the 500,000 number that you are talking about, can they go to up to 500,000, up below 40% household?
5 lakh, 5 lakh
5 lakh, yeah.
insurance. Yes,
Yeah.
yes.
So can they go to the private guys with
Yeah.
that insurance?
Yeah. So initially, what they are saying is the 5 lakh rupees insurance is for the per family basis, and initially they will be covering the poorest section, the most deprived ones. As far as the facility that they can use is, they are open for all. I mean, you can use your government services, you can use your private services also. So there is no distinction between them. But the only thing is the penetration would be very slow because they would be following a more of a, you can say a method wherein the poorest would be first covered, which is again, covering the last mile is the most difficult. So it will take a lot of time when you start covering a decent number. But as far as facility is concerned, you can use all.
Yeah, it seems there are no questions on Zoom as well. Anybody in the hall? Great. Thanks so much. Thank you, Abhishek.
Thank you.
Thanks for the presentation.
Whenever things got rough, I always remember what my father used to say.
Running a business does test a man, my son. There are ups and downs, glorious highs, and sometimes a low that leaves you feeling defeated.
The character of a man and the character of a business are not very different, are they?
Yes, but when the chips are down, we must stand up, dust ourselves off, and motor on.
Volatility. It's a funny thing. It makes you question yourself and wonder if you've made all the right decisions.
Sure, you can question some of your decisions, but stay steadfast on your goals.
Dad always said, there are no shortcuts and no quick profits.
There are no free lunches, are there? There is only one
Right way.
At PPFAS, we think like Rahul and his father. That volatility is a fact of running a business. And buying equity shares is like owning a part of that business. We use value investing principles to manage your money. This means we invest in the right businesses at reasonable prices and for a longer term.
PPFAS Mutual Fund. There's only one right way. Mutual fund investments are subject to market risks. Read all scheme-related documents carefully.